If you're considering surgery for Morton's neuroma, common condition associated with the forefoot, this talk may very well answer a number of questions. However, you will find a lot more information in my book, which is Morton's Neuroma, from a patient turned podiatrist. I'm David Tollerfield, a former podiatric surgeon. I'm also a patient, and I had surgery on my foot 9 years ago, and I'm also an author. In this talk, I want to cover the expectations from surgery, and I'm concentrating on some of the risks as well as the successes. I mean, the surgery itself is successful, but there are things that I think you need to know and things that you may not always be fully aware of following the consultation. And one of the problems with consultations is that you have a lot of information thrown at you, and as a consequence, there's every chance that you might not take everything in. The other aspect is, after surgery, what can you expect? Now, I'm not going to cover everything possibly in this sort of 20 to 25 minute talk, simply because there's so much material, but I want to give you an overall impression, and that is why I've written the book, so it's got a lot more information in it, with case histories, patient feedback, and some facts which are very important, because they're not just a question of saying, in my experience, these are actually recovered from a wide range of sources. Now, in the other parts of the talks I've put together, one is self-help in part one. In part two, I looked at some of the newer techniques which avoided direct open surgery, although some of these techniques were slightly invasive and needed a local anaesthetic, but were basically day surgery. The surgical techniques I'm going to be talking about in this film are also day surgery, so have no fear, you shouldn't need to go into hospital and stay overnight unless there's a reason for it. You now have a choice if your life has been affected. In the first part, we looked at looking at those key aspects, including the footwear relationship with the forefoot, together with insoles, things that go inside the shoe, called orthoses, or insoles with pads. And then we started to move towards injections. These are particularly valuable, but may not always work, for the reason that that lesion size, that's the size of the neuroma, is too large, too damaged, too scarred in, and literally will not be influenced by any other treatments. And sometimes that's not understood by most patients, and that's why other treatments fail. It's not that the clinicians failed, but the assessment, particularly from ultrasound diagnostics and magnetic resonance imaging, MRI in other words, provides a much clearer distinction as to how that particular pathology is developing. So what drives us towards surgery? Well, our quality of life has been affected. Nothing else works, and your life is frankly miserable. At night time, you have pain. You take painkillers that don't work. You've got limited mobility, so you can't walk as far, can't undertake those jobs that you want to do, whether they're hobbies or whether it's part of your career. So any dependency on analgesia, pain medication, is an indication that you do need to seek consideration for surgery. So we've done the first part and the second part. Now we're going to concentrate on surgery. I like to talk about timeline, and the first part, the shaded arrow to the left, really doesn't give us too much in the way of identification of the problem. You don't realise that something's happening for maybe 6, 12, even 24 months, as I experienced. And I should have known, because I was a podiatrist. So these things creep up on the best of us. The timeline is definitely unpredictable, but once the symptoms start to intensify from not just pain, but you get to crushing sensations, the stone in your shoe, you might have shooting pains in the foot, tingling in the toes, and the consistent frequency that you're experiencing discomfort means that other treatments are not going to work, and you need to get in there and take the nerve out. Essentially, that is what the surgery is about. So surgery is really where we're at for this talk. Now, the size of the lesion, the neuroma, is measured usually with an ultrasound or MRI. But it's not until we actually take the nerve out we really understand the size, and sometimes this can be larger. So it's size, size, size. The bigger it gets, the more difficult it is for you to actually successfully receive the benefits that you were hoping for. So what is the size? Well, the size, usually anything from 6 to 10 millimeters, starts to make it difficult. These aren't values that have just been plucked from thin air. There have been a number of different research papers, clinical research papers, which have been validated, which means to say they are reliable and they give us a clear indication as to why things don't work. The problem is that clinicians may not always be aware of these research projects themselves and haven't necessarily stepped into the deeper realms of understanding what it is like from a wider range of patients gathered together to collect that data. So that's where this talk, that's where my book comes in. So we're faced with surgery. Okay, if you don't want surgery, that is your decision. But surgery is something you may have to consider. Bear in mind that this can be done under local anaesthetic, but if you really are very anxious, you can have sedation. Sedation just kind of takes the edge off your anxieties, but doesn't prevent you from leaving the hospital. Or you can have a full general anaesthetic. This is where you're completely unconscious, don't know anything about it whatsoever. Again, this is only a short procedure. They tend to take 15 to 20 minutes for single neuromas. If it's in both feet, then it may very well obviously take longer. But generally speaking, you're not going to be in theatre for more than an hour for even the most complex conditions, unless you've got other foot deformities that need to be managed at the same time. So now it's